Hi, everyone. Welcome to our presentation. I'm Cassie Horvath. I'm a current undergraduate student at the University of Iowa. I'll be graduating in May with a bachelor's in health and human physiology with a focus in health studies. Our presentation today is regarding disparities in COVID-19 in incarcerated individuals within the United States.
And welcome, everyone. My name is Dr. Gayle Walter, and I'm a lecturer in the Department of Health and Human Physiology at the University of Iowa. So what we'd like to talk to you about today is not necessarily presenting a research study, but more so looking at a review of the literature as it's focusing on health disparities in COVID-19 infections for individuals who are incarcerated compared to individuals who are not incarcerated. So I'll just provide you with a quick introduction of what we're going to be talking about today. So the health disparity, as I mentioned just a little bit ago, is the COVID-19 infection rate for incarcerated individuals in the United States is approximately 3.3 times higher than the general United States population. And mortality rate is also pretty significantly higher at almost 2.5 times compared to the general population. There are many causes for this disparity that we'll be talking about today. And those causes would include facility overcrowding, improper health response, as well as inconsistent data collection related to COVID-19 in correctional facilities. Some of the solutions that we're going to be presenting today for you to consider are decarceration, reform of inmate health procedures and medical care, as well as having transparent data collection to identify trends. We would also like to share this quote with you that both Cassie and I like, and it is stated by Colette Peters, who is the director of the Oregon Department of Corrections. So prisons were not made with public health in mind. They were made to be as efficient as possible and house as many people as possible. So not really considering the implications of a huge pandemic such as COVID-19. So we'll begin with sharing just a snapshot of some data. So as of April of 2022, so pretty recent data, there were approximately 597,600 cumulative cases of COVID-19 in the US correctional facilities, and also 3,000 deaths also related to COVID-19. And when we look at the health disparity between the non-incarcerated population compared to the incarcerated population, those statistics are pretty staggering as well as disheartening. So from data collected by the UCLA Law COVID Behind Bars project, they collected information from April of 2020 through 2021. So cumulative incident rate of COVID in the non-incarcerated population were 9,350 cases per 100,000 individuals. But then if we look at the incarcerated population, pretty staggering with that incidence rate being 30,780 cases per 100,000 individuals compared to that 9,350. And then also looking at the standardized mortality rate, there were about 80.6 per 100,000 individuals in those that were non-incarcerated. And then take a look at the incarcerated standardized mortality rate, 199.6. So definitely you can see the disparity between those two groups. And lastly, I want to show you hospitalization as well as mortality. And these aren't from the whole entire United States, but just a snapshot from an observational study that was conducted at 2 Henry Ford Health System hospitals in Michigan from March to May of 2020, where we are still continuing to see these disparities. So based on the data that they collected in Michigan, there were 589 non-incarcerated individuals and 108 incarcerated individuals hospitalized due to COVID-19 during that time frame. And what the researchers found was that incarcerated individuals were more likely to be admitted to the ICU, require vasopressors, as well as intubation. And also prisoner status was also associated with approximately twice the risk of death compared to individuals that were categorized as non-prisoners. So definitely, we are seeing those disparities in hospitalization rates as well as mortality. So now we're going to take a look at those determinants that do influence that health disparity in COVID-19 in incarcerated individuals compared to those who are not incarcerated.
As Gayle discussed within the data, it's obvious that there is a health disparity. And so now I'm going to talk about the determinants and also the recommended strategies of what we have to overcome these determinants and decrease a health disparity. This slide is just an overview of the determinants that we're going to discuss. We're seeing increased infection rates due to inability to social distance, under testing, improper cleaning and sanitation procedures, initial uneven vaccine rollout and staff hesitancy of the vaccine, and inconsistent mask enforcement. We're also seeing increased mortality rates, not only due to the determinants that are causing higher infection, but also some specific ones that are related specifically to mortality, such as improper medical isolation techniques, under testing, higher prevalence of pre-existing health conditions, and reluctancy to seek medical care. The first one we're going to discuss is the impossibility of social distancing within correctional facilities. So as we know, outside of correctional facility walls in the US general population, social distancing was one of the greatest mitigation procedures encouraged by public health officials. However, for incarcerated individuals, social distancing was nearly impossible. Through an incarcerated individual interview through the Marshall Project, which has been an excellent data source for tracking COVID-19 within correctional facilities, this incarcerated individual described social distancing within their own facility as not only just impossible, but as a joke. The CDC, as well as the American Correctional Association, also known as the ACA, did have set guidelines that involved restricting or limiting visitation, canceling group activities, reduction in living units, prevention of unnecessary movements and mixing of housing units, and use of quarantine and new inmate quarantine. However, due to overpopulation within these facilities, these guidelines were necessarily impossible. For example, the ACA recommended that cells in correctional facilities should have at least 25 feet of space per person in each cell that are not occupied by furniture or other items. However, most facilities, due to a lack of space because of overpopulation, had beds as close as 3 feet apart. Now, many people would think that the lack of adherence to these social distance guidelines was due to staff negligence. However, most of the real obstacle lies mainly within the overpopulation and the lack of control that comes along with managing overpopulated facilities. So the next slide that we're going to look at is kind of a visual representation of the social distancing obstacles that we are seeing in terms of quarantine. Now, this was adapted from a study done in October of 2021 that studied 45 Department of Correctional Facility systems and their adherence to CDC social distancing guidelines in terms of quarantine. Now, the first most shocking part of information I found from the study was that not a single of these studied correctional facilities followed all of the CDC guidelines. And the one specifically I want to look at is the yellow bar, which discusses the intakes that are quarantined. And this was 64%. While 64% seems like a higher number, that's still leaving 44% of systems vulnerable to outside exposure. And these inmates that are coming in are coming from outside sources, which could leave the other incarcerated individuals vulnerable to that outside exposure. The problem is that none of these CDC guidelines are being adhered to at or near 100%, once again, leaving these incarcerated individuals vulnerable to and not being adhered to full mitigation strategies. The next one we want to discuss is undertesting. The importance of mass testing was especially emphasized through a CDC study, which was done in April to May of 2020. And this study was done on 16 US prisons and jails, and they found a 12-fold increase in the number of cases than only symptomatic testing used previously. Now, the reason now they found that higher cases was they were finally identifying incarcerated individuals that were pre-symptomatic, asymptomatic, or symptomatic, and they were reluctant to report their symptoms out of fear of being put in medical isolation. Now, with such a huge public health platform as the CDC is, some would expect that all symptoms would then adhere to mass testing within their facilities. This cannot be declared, as data was very hard to find regarding testing. But what the UCLA COVID Behind Bars project did find in October of 2021, that even in states that had the most tests in their prisons, such as Michigan, New Jersey, and Illinois, incarcerated individuals still had been tested fewer than 30 times on average during the first 18 months. And while this might seem like a lot, if you compare to the US general population, where some individuals were tested on weekly or daily basis within their schools or other large congregational facilities in which there was going to be a lot of exposure, this is a very small amount, especially for the amount of infection and mortality rates being seen within the correctional facilities. Further, in October of 2021, the National Commission on COVID-19 and Criminal Justice found that states that did not utilize mass testing had death rates of COVID nearly 8 times higher than the US population. And COVID positivity rates were almost double for states that utilized mass testing procedures. To summarize this, widespread testing should have been implemented in every system. The next determinant we're going to discuss is uneven vaccine rollout. When the vaccine was first introduced within the United States, states had allocation plans that were in terms of phases for who would be eligible within each of those phases. This is a bar graph that's a visual representation of those plans. And this was collected on December 31st, 2020, when the vaccine was introduced kind of early December 2020. So within the red bars represents the incarcerated population and when they were in what states had planned for them to receive the vaccine during which phases. The majority of states didn't have a specified phase for incarcerated individuals, despite the knowledge that incarcerated populations were seeing such high of infection and mortality rates. And it was of utmost importance that these individuals had eligibility for the vaccine. However, 100% of long-term care facility residents or 100% of states involved long-term care facilities within phase 1, which were seeing very similar rates of infection and mortality as prisons and jails. Further, 59% of states included individuals over 65 and up who are in the incarcerated system, but may have not been eligible for the vaccine due to incarcerated status. Also, 49% of jail and prison workers, or 49% of states included prison and jail workers within that phase 1. The lack of inclusion for incarcerated individuals within phase allocation further emphasizes the disparities seen for their incarcerated population for COVID-19 mitigation efforts. So along with uneven vaccine rollout, we have the presence of staff vaccination hesitancy. So as we did see, many states involved the correctional facility staff within that phase 1. However, there was still high rates of staff hesitancy to receive the vaccine. So within the 21 agencies that had formal vaccination data as of 2021, and this is from the UCLA COVID Behind Bars project, 64% of incarcerated individuals had been vaccinated. The general US population was at 71%, and 47% of states, 47% of staff had received at least one dose. Some states reported as little as less than 10% of staff that received the vaccine. And as of April 2021, staff accounted for more than 40% of the new cases. So it raised the emphasis of how important it was for correctional staff to be receiving the vaccine due to their daily exposure outside of the correctional facilities and exposing the incarcerated individuals to these cases. The next one we're going to discuss is sanitation and mask enforcement. This was really interesting information for me to go into, as it kind of exposed some of the odd mitigation procedures that correctional facilities were using during this time. So in August of 2020, only 15 state prison systems required incarcerated individuals to wear masks, and 27% or 15 state prison systems required incarcerated individuals to wear masks, and 27 required staff to wear masks. Just to put things into perspective, mask mandates were recommended by the CDC in April of 2020. Therefore, we should have seen probably higher amounts of mask enforcement within these facilities due to the months difference. And this was data reciprocated from the Prison Policy Initiative. Further, mask adherence, even if it was implemented within the states, it cannot be proven that it was adhered to or was consistent due to the large amount of individuals within these correctional facilities, and lack of control is to be assumed. Otherwise, the next thing within mask enforcement is the sanitation practices. In many correctional facilities, alcohol-based products such as hand sanitizer and alcohol-based wipes are considered contraband, and incarcerated individuals do not have access to them. In an interview by the Marshall Project of an incarcerated individual from the Washington State Prison, this individual discussed that within their facility, they were given a mild cleaner for their own personal use, and some rumored and joked that was safe enough to drink, therefore most likely not strong enough to properly disinfect. They were also given socks to use on the phones to try to decrease contact, surface contact. Then one of the other things regarding disinfection is that most systems did use trusted incarcerated individuals within the facilities as janitors, or they were called porters, and they were responsible for disinfecting the common areas. However, these individuals were only given as much as $55 a month, and thorough cleaning should be questioned necessarily, as they don't have the proper training or maybe just the proper motivation to properly clean these areas. The cleanliness of the facility should have been top priority. Public health officials and correctional facility staff need to come together and find ways in which incarcerated individuals can be given the proper cleaning tools to protect themselves and ensure their environments are being disinfected properly on a routine basis. The final determinant we're going to discuss is the reluctancy to seek medical care. Many facilities, due to lack of space, were using their solitary confinement as their medical isolation. Many incarcerated individual testimonies said that their facilities with their medical isolation were windowless. They were not able to have their possessions. They were given the same clothes to wear for the entirety of the 14-day quarantine and did not give them many access to showers. Therefore, these environments did not promote healing. The only resemblance between medical isolation and solitary confinement is the physical separation of people. It should not have any resemblance in terms of medical isolation and solitary confinement for healing. The next two factors that kind of contributed to reluctancy to seek medical care is lack of trust in facility and medical officials to receive care, and delayed medical care of non-urgent medical concerns. Prisoner or incarcerated individual interviews through the Marshall Project as well stated that sometimes you would not be seen by a physician in 3 to 4 days after inquiring to receive medical care. In 2016, the Bureau of Federal Prisons stated that medical staff was actually at 17% less than what was needed to provide ideal care. Therefore, the delay for incarcerated individuals to seek medical care is most likely due to staffing issues. Further, a law professor from Loyola University of New Orleans told the Marshall Project that many medical staff in prisons have inadequate credentials or derogatory medical records, which may fuel distrust within incarcerated individuals to seek care, knowing that they may not be receiving proper care. The final factor for reluctancy to seek medical care is the presence of a medical copay. The Prison Policy Initiative found that out of 22 out of 37 systems, they still have a suspended halt on medical copays. This was instilled during the pandemic to try to promote individuals to seek medical care due to medical concerns. However, since some states have just continued the suspension of medical copays for only COVID-related symptoms, or have just completely reinstated copays. To kind of put in perspective of what a medical copay would cost within these facilities was usually around $3, or in some extremely high states, $13.55. Incarcerated individuals typically earn around 14 to 63 cents an hour. So the financial burden of receiving medical care was a strong determinant for individuals to seek care within the facility, especially when they feel they're not receiving proper care or they're receiving delayed care. So now we're going to discuss some of the recommended strategies of how we can overcome these determinants. The first one is continue data reports of vaccination rates, active cases, and mortality rates for all systems. In 2020, we saw it was very easy to technically find data. As the pandemic kind of went on in 2021, we started to see a decrease in the amount of data available. Some states use the excuses as a decline in cases, so they didn't feel the need to further collect data, waiting on autopsy reports, or some states even use the excuse of it taking away time for caring for their patients. Data collection is increasingly important as we have transparent, accurate, and widespread data to identify trends within COVID-19, as this will allow further ability of strategizing solutions and understanding what solutions prove to be effective. Other strategies are increased education regarding COVID-19 and vaccination for inmates or incarcerated individuals, vaccination mandates for correctional staff, reform of inmate medical care to reduce reluctancy and distrust, and continue elimination of medical copays in all state systems. However, the greatest recommended strategy is decarceration. As we've seen, overpopulation is fueling most of these determinants and the inability to carry out mitigation strategies. Prisons holding between 94% and 102% of their capacity were found to have higher rates of COVID-19 and deaths than prisons holding 85% of capacity. This is data found by the Prison Policy Initiative, and this further emphasizes the importance of overpopulation and how this can affect prisoners' health, especially during times of a pandemic. So we did see a decrease during the pandemic. We saw a 13 to 15% decrease in state and federal prisons and a 25% decrease in jail populations. A misconception is that this was due to releases. However, it was actually due to admissions, as many were due to court delays or suspension of transfers for local jails. The Bureau of Justice Statistics actually found prisons released 10% fewer people in 2020 than in 2019. And as of December 2020, state prisons were still at 90% capacity or more, which needs to be further decreased through permanent policy change. So then on the next slide, we're going to talk about this just a little bit further using a visual representation. So these graphs were adapted from the Prison Policy Initiative, and the general visual I want to discuss is the trends that we are seeing. Through figure 4, this is the prison population, and in figure 5 is the jail population. The general trend we see is a dip, and then it goes right back up. And so figure 4 is from January 2020 to December 2021, and figure 5 is from March 2020 to September 2021. So March 2020, or in 2020, we see that decrease. However, we see that most of them are going back up to 2021 due once again to the lack of permanent policy change. So to wrap things up, share some final thoughts. The pandemic exposed and emphasized the dangers of overcrowding and the need for reform of the criminal justice system and correctional facilities. Through this, policy change and reform of the criminal justice system are permanent solutions to fix and prevent overcrowding, reduce health disparities, improve the health of incarcerated individuals, and allow thorough preparation of future infectious disease control in facilities. To end our presentation, we have listed our contact information with any questions. Thank you so much for joining us today.